Welcome this afternoon. We are here with Ultimate Opinions in Medicine at our lung tumor board. My name is Mark Sosinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm joined by my four panelists. I'm going to have them introduce themselves. I'm going to start with Dr. West.
Hi, I'm Dr. Jack West. I'm a medical oncologist with a focus on thoracic oncology. I'm an associate clinical professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area.
Hi there, I'm Kristen Higgins. I'm a radiation oncologist at Winship Cancer Institute of Emory University in Atlanta, Georgia. I specialize in thoracic malignancies, and I'm an associate professor and could be here discussing cases with everybody.
Hi, I'm Varun Puri. I'm a thoracic surgeon at Washington University in St. Louis, and I also serve as a professor in the department and the program director for our cardiothoracic surgery residency program. Glad to be here.
Hi, I'm Michelle Ginsberg. I'm director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center in New York City. I'm also vice chair of education in our department and professor of radiology at Weill Cornell Medical College in New York.
He's a 64-year-old gentleman, current smoker, has a greater than 40 pack year exposure. We're told he has stage 4 adenocarcinoma of the lung. He initially was treated with pemetrexed and carboplatin, but we're told he was progressed and then placed on second-line atezolizumab with a very good response until lasting up until 14 months. Apparently, had a treatment break due to financial toxicity, apparently. PET scan now shows disease progression, and the atezolizumab was restarted. And we're told after 4 additional cycles that the patient has stable disease. Again, his presentation is summarized here. He presented with left arm numbness, with a stable cough, said to have an excellent performance status. His past history is significant for hypertension, type 2 diabetes, COPD. He is, as I mentioned previously, a current smoker with a 40 pack or greater history, no particular family history. I'll turn it over to Dr. Ginsberg once again, just to briefly review the CT and PET scans.
Yes, we don't have the actual images, but they were reported as having a 3 centimeter by 1.5 centimeter mass in the right upper lobe. And the PET scan showed a lot of diffuse disease, metastatic to the in the right adrenal, right renal, left adrenal, the right spermatic cord, also in the anterior pelvic wall lesions, and ipsilateral hilar lymph nodes. And the abdominal wall lesion was biopsied, which demonstrated a metastatic carcinoma consistent with the primary.
Yeah, so he's TTF1, NAPSINA, CK7 positive, pretty consistent with an adenocarcinoma. We're also told that his PD-L1 is greater than 50%. I'd like to know how much greater than 50% is it, but we know he's in what we would be considered the high positive. We're told there's a limited molecular workup, and he's negative for EGFR BRAF mutations and negative for ALK fusion. Back in December of 2018, he initiated treatment with pemetrexed carboplatin. You can see there, Dr. Ginsberg, you want to comment on the PET scan in February 2019?
Yes, we have and actually, if you can advance it to the next image, and it demonstrates the spiculated right lower lobe nodule, which is the only single avid nodule seen, and that was the only reported finding.
So we go back just to the oncologic history here, and I'll ask Dr. Higgins. We're told in February 2019, I guess because of the pain, the patient receives a single fraction palliative radiotherapy to the spine. I think you mentioned that earlier on. Could you comment on that practice?
Sure. So bone metastases are obviously a problem in our lung cancer patient population. we can use a multiple different radiation options for bone metastases. 8 grade times 1 is a good option. You can give it in 1 fraction. It's very well tolerated. There is actually new data coming out that stereotactic body radiation therapy can be somewhat more effective in the pain relief for these bone metastases, and you can escalate the dose higher than 8 gray. You can give up to 16 gray, which is double what you could do with the 8 gray per fraction. It's a little bit more technical. You have to use an MRI for treatment planning, and it takes about a week to develop the treatment plan from the time that the patient undergoes simulation. So if you have somebody that's in a lot of pain and you need to get that fraction in right away, it's easier to give this 8 gray. But if it's somebody that can wait and you can get the MRI and do the more technical radiation planning, SBRT may be a good approach just because you can get better pain relief, better local control in the long term.
And while I have you commenting, Dr. Higgins, we're told almost over a year later, I guess, consolidative radiation therapy to the right perihilar area. We saw the image. I'll just forward to the image. I don't know if this is the image that this was the lesion that was radiated, but thoughts on that?
Yeah, so we do use stereotactic radiation for what we term oligoprogression. So if a patient is responding everywhere on the body and there's one area of gross disease that is progressing, radiation can be helpful to address that area that probably has resistant clones. And then you can keep the systemic therapy that's otherwise effective, keep it going. Now, I will say this is something that's done in practice frequently, but there's not much data for this approach. And sometimes we get pushback even from our payers and our insurance companies, and we're not able to offer this radiation treatment. But my group has recently just demonstrated an abstract on our results with SBRT for oligoprogression. And it does allow patients to stay on their current regimen for a longer amount of time. And that's beneficial, especially if you're already in the second line setting, you don't have a great third line option. So I think that it can be helpful in those situations.
Okay, thank you. So after the first line carbopemetrexid, and at the time of progression, the patient was started on atezolizumab, I mentioned before, apparently suffered from financial toxicity, took a bit of a drug holiday, as noted there, for actually a reasonable amount of time. Following that holiday, PET demonstrated disease progression, and the atezolizumab was restarted. I think the PET scan, we're told, is stable in that. We've talked about that already. So back to Dr. West. Here's the question. Should it be continued with stable disease? And if so, for how long? Would you recommend any sort of change in treatment at this point? This is kind of what we used to do before what I refer to as the immunotsunami hit. Most of these patients would be getting chemo IO right up front and continue on IO. We talked about that with case number 1 in terms of the duration of IO therapy. But what are your thoughts in this case in terms of the second line atezolizumab?
I would say that this is a setting where I would be inclined to keep it going, definitely for now. I think you could argue about whether once you get to a total of 2 years, you'd stop, but this is a patient in whom we've already seen that there is a proclivity to have progression despite the consolidation radiation off of treatment. So to me, the question is, are you giving alligator repellent and, continuing treatment well beyond a point where there's a threat? I think we don't want to treat anyone longer than they need to, have them tethered to the infusion center every few weeks. But I think that what we see from this patient's history is that's not likely to be the case, that this is needed to continue to suppress the disease. And I would be inclined to have a patient, have this patient continue on it at least for the foreseeable future, probably ongoing in the absence of progression or any prohibitive toxicity. And if there were isolated progression, I would consider local therapy to address that in the absence of more diffuse progression.
Yeah, I would agree. I think, we don't know the details of why the atezolizumab had to be stopped, the details of the financial issues and these sorts of things. Fortunately, they seems to be sorted out. And the patient seemed to have disease control as best we can tell from the presentation. And I would agree with your comments. I would keep this going for as long as the patient didn't have disease progression or some sort of prohibitive toxicity. Just out of curiosity, Dr. West, in any role for using a different IO agent in this setting? I'm not aware of any data myself. I think we have generally assumed, particularly in the second line setting, that many of these, whether they're PD-1 or PD-L1 antibodies, seem to have very similar outcomes with these patients. So that's question number one, and then I have a second question.
Well, I did flicker on that at one point as the case was going on. I think you could choose to replace atezo with pembro, or cemiplimab. These agents all three have an approval for patients with high PD-L1 in the first line setting, and there's others that are approved beyond that as well. So, and the data I would characterize as far more similar than different for all of them. I am not aware of any compelling data to speak to meaningful efficacy of one beyond what you'd expect from any other, in terms of switching. And that even goes for Nivo-Ipi or something like that, a combination that's of different agents. Not to say that we can't find that in some subsequent studies, but we don't have data that I know of to speak to that. And I'm sure that this has been done a lot off protocol over the last 5-7 years, that there have been multiple agents out there. And the fact that it's hard to even know of any case reports, let alone good trends or case series, to me suggests that there's probably not a strong evidence-based approach to this. So I don't think it'd be wrong, but I don't have much enthusiasm for it. Do you have any experience or knowledge of data to speak to switching and getting better results with one PD-1 or PD-L1 inhibitor after another?
No, there are a couple of trials ongoing looking at that question, but I can tell you the early information or data from them is not very encouraging, as one would expect. I don't. That's not something that I would consider doing at this particular point. And I guess the only consideration is, for some reason, it was financially better to get one versus the other. That would be a reason. But I think we've generally, at least as monotherapy, assumed that the benefit is very similar amongst them. Let me ask you this, though, Dr. West. If we think of the immunity cycle, it starts with the release of tumor antigens and those neoantigens that hopefully are recognized by our immune system. I always felt that's kind of the job of chemotherapy, is to kind of have that cytotoxic response, release those neoantigens where the immunotherapy can be probably most effective. Any compelling argument? This is a gentleman that we would all argue that if we all saw him in our practice today, may actually get combination chemo IO. This patient was treated sequentially. Any magic to using them together, the IO and the chemo, and would that be something you might consider at the time of progression?
Yeah, that's another thing that I had a fleeting thought about. I think it's a possibility, but we haven't seen that yet. I personally would be more inclined to favor that if this gentleman had a hint of a benefit from chemotherapy before, but it was really primary convincing progression. And I would say we don't have data. Wouldn't be a terrible idea, but I don't think that I would anticipate much incremental benefit in a patient whose cancer had grown clearly and quickly through chemotherapy up front.
Yeah, I would agree with that. Of course, obviously, all of these cases need to be individualized. Patient preferences need to be taken into account in these sorts of things. But I would think, as a general statement, that I would agree with your comments. And you could follow the strategy that if it's not broken, don't fix it, right? I mean, this gentleman. We all know that one of the advantages of immunomonotherapy with these drugs is they're incredibly well tolerated for the most part in the vast majority of patients. So it's a really nice balance between disease control and side effects. So I would.
But we do need to. I'm sorry, I don't mean to step on your or overstate, but. Yeah, I think we don't want to give more than necessary or less than necessary. There are studies that are ongoing trying to tease apart who needs monotherapy and who's better served by a combination. I think for someone at least who has a higher, and we don't know how much higher this is, whether it's 50% or 70 or 90%, I'm more inclined to go with monotherapy for someone with a quite high PD-L1, because it's not just a binary or clear separation of high or low, but how high really does seem to correlate with the probability of a very gratifying response. So I think that's an open question. And I would just come back to the point that you did state of that, yeah, if costs were significantly different for one over another, I think one corollary of them being more similar than different is particularly if this patient is feeling the financial strain of one more or less than another, that would factor into my equation of which one to give.
Yeah, thank you for the comments on the very high PD-L1. I completely agree with you. But the other factors that I use in that setting are disease burden and symptom burden, in terms of, do you use IO monotherapy or combination with chemotherapy? So to summarize this case, we agree with the current management. We believe that atezolizumab should be continued. And if so, for how long? Our recommendation would be for, like we said in previous cases, up to 2 years, and then it would have to be individualized. And we certainly don't feel a need for any change in treatment at the current time.